All right, in this explainer, we're going to break down the core pathophysiology of Parkinson's disease. Our goal here is to build a solid, high-yield foundation so you can really understand the mechanisms behind this critical neurodegenerative disorder.
So, here's our roadmap. We've structured this in 5 logical sections. We'll start with what the disease looks like clinically. Then we'll dive deep into the underlying cellular problem. After that, we'll map out the brain circuits that are affected, connect that pathophysiology back to the symptoms, and finally, we'll wrap up by looking at the therapeutic strategies that target these pathways.
Okay, let's jump right into Section 1, the clinical picture. Before we can understand the why, we have to be rock solid on the what. The classic observable signs of Parkinson's. The clinical diagnosis really hinges on 4 cardinal features, and there's a great mnemonic to remember them. TRAP. That's T for tremor, specifically a tremor at rest. R for rigidity in the limbs and trunk. A for akinesia or bradykinesia, which just means slowness or even absence of movement. And P for postural instability, which affects balance, usually in the later stages of the disease. Now, that tremor in Parkinson's is very specific. We call it a pill-rolling tremor because of the way the thumb and index finger move. And here's the crucial part. It's most obvious when the limb is completely at rest. As soon as the person goes to do something intentionally, the tremor tends to get better or even disappear. That's a huge diagnostic clue. Next up is rigidity. When you passively move a patient's arm, for example, you might feel this sort of ratchet-like start and stop catchiness. We call that cogwheel rigidity. Or you might feel a smooth, sustained resistance all the way through the movement, which we call lead pipe rigidity. This stiffness is what leads to that classic stooped posture and the expressionless, masked face or hypomimia. Okay, Section 2, the core deficit. So we've seen the clinical signs. Now let's get to the root of the problem, down at the cellular level. And it all comes down to a profound loss of dopamine. So what is Parkinson's at its core? It's a progressive neurodegenerative disorder, and the pathology is incredibly specific. It's caused by the death of dopamine-producing neurons located in one particular spot in the midbrain, the Substantia nigra pars compacta. Now, here's a really critical point. The brain is amazing at compensating. In fact, the classic motor symptoms of Parkinson's usually don't even show up until about 60% of these dopamine neurons have already been lost. This explains why there's such a long preclinical phase where the disease is progressing silently. If we were to examine the brain tissue itself, say on autopsy, we'd find 2 key pathological hallmarks. First, the Substantia nigra, which literally means black substance, would look pale because the pigmented neurons have died off. And second, if we look inside the surviving neurons, we find these classic little clumps called Lewy bodies, which are made up of misfolded alpha-synuclein protein. Okay, Section 3. This is where we get into the real neuroanatomy, the basal ganglia motor loop. To really understand how losing dopamine causes motor symptoms, we first have to understand this incredibly important circuit that regulates our movement. Think of this circuit as having 2 arms. First, we've got the direct pathway. This is your go signal for movement. It starts with the cortex exciting the striatum. The striatum then puts the brakes on the globus pallidus internus, or GPI. Now, because the GPI's normal job is to inhibit the thalamus, inhibiting the inhibitor, that's a double negative, lets the thalamus off its leash. This disinhibited thalamus is now free to excite the motor cortex, and boom, you get movement. The second arm is the indirect pathway, and this is your stop signal. It's a little more complex, so let's walk through it. The striatum inhibits the globus pallidus externus. This frees up the subthalamic nucleus, or STN. The newly active STN then excites the GPI, which then slams the brakes on the thalamus. The end result? Movement is suppressed. In a healthy brain, you need a perfect balance between this go and stop signal. So you're probably wondering, where does dopamine fit in? Well, it's the master regulator that fine-tunes this whole system. Dopamine acts on the striatum in 2 ways. First, it binds to D1 receptors, which gives a boost to the go pathway. At the same time, it binds to D2 receptors, which puts the brakes on the stop pathway. So the net effect of dopamine is to tip the scales in favor of movement. It's pro-movement. Okay, Section 4. Now it's time to put all the pieces together. We're going to connect the dots and see exactly how dopamine loss in this circuit leads directly to the clinical signs we talked about earlier. This right here is the most crucial concept. In Parkinson's, when you lose dopamine, you get a double whammy.
There's less stimulation of the go pathway, so it becomes underactive. And there's less inhibition of the stop pathway, so it becomes overactive. The whole system gets heavily biased against initiating movement. And we can draw a straight line from this pathophysiology to the patient's symptoms. The underactive go pathway means less excitation going back to the cortex. That's what causes bradykinesia, or slowness of movement. The overactive stop pathway means the thalamus is being inhibited way too much, which leads to akinesia, that difficulty just getting a movement started. And this whole circuit imbalance is what causes the rigidity and the tremor.
And just as a quick clinical pearl, this is super high yield for exams. It's vital to know the difference between a Parkinsonian tremor and a cerebellar tremor. Remember, the Parkinson's tremor is a resting tremor. It gets better with action. A cerebellar tremor is the opposite. It's an intention tremor, meaning it's absent at rest but gets worse as you move towards a target. All right, on to our final section, therapeutic strategy. Now that we understand the core problem is a lack of dopamine signaling, the way we approach treatment becomes very logical. The entire game plan for treating Parkinson's is built on one simple principle. We have to find a way to restore that lost dopamine signaling. If we can boost dopamine's effect in the basal ganglia, we can help rebalance that motor circuit and relieve the patient's symptoms. So how do we do that? Well, we have a few main tools in our pharmacological toolbox. We can try to replace the dopamine using its precursor, levodopa. We can use dopamine agonists, which are drugs that just pretend to be dopamine and stimulate the receptors directly. Or we can use drugs that block the enzymes that normally chew up dopamine, allowing the little dopamine that's left to stick around and work for longer. Now, the most effective treatment by far, levodopa, works because of a really clever pharmacological trick. See, you can't just give a person a dopamine pill because dopamine can't get past the blood-brain barrier, but its precursor, levodopa, can. So we give the patient levodopa, and we give it along with another drug called carbidopa. Carbidopa's job is to block the conversion of levodopa to dopamine everywhere except the brain, which maximizes its effect right where we need it and reduces side effects. But what happens when medications aren't controlling the symptoms well enough anymore? For those patients, we have a more advanced option, deep brain stimulation, or DBS. This is a neurosurgical procedure where an electrode is implanted into a specific part of the basal ganglia. This electrode then sends electrical impulses that help override the abnormal signaling and re-regulate that dysfunctional motor circuit. You know, everything we've talked about so far, levodopa, DBS, all of it, is symptomatic treatment. It's managing the consequences of the dopamine loss, but it doesn't stop the neurons from continuing to die. And this brings us to the most important question for the future. How can we develop treatments that target the underlying disease process itself? That's the real challenge, finding a way to protect these neurons and actually halt the progression of Parkinson's disease.